Okay, I think it's recording. So
yeah, we are live on YouTube.
yes. So I think you need to put yourself on spotlight. Better.
Yeah, but
thanks.
that's okay.
So I invite everybody for this one more session of Masterclass of Fertility series. Though it is a Saturday, I think we have close to 200 people joining us. And I think we are very, very grateful to everyone who is joining us live when we announce our classes. And I really thank Dr. Jay, who has been so committed in spite of his travels and work commitments and health issues. But the good thing is, like, the teaching has been going on without a break, and it's very, very important to acknowledge that he is teaching without knowing who is on the other side of the camera and how it is received without any expectations. So welcome to this session, which is going to be very interesting because many times we receive doubts about HMG, FSH, urinary FSH, urinary HMG, rFSH, rHMG, so many things. Over to you, Dr. Jay. I think you can take over.
Yeah. So, Shilpa madam, I would directly like to share screen and you stay unmuted, okay?
Yeah.
Okay. So you guys can see my screen, right?
Yes.
Okay. So today we are going to be having a session describing HMG versus recombinant FSH. Okay. And in HMG also we are trying to speak specifically of hpHMG. Okay, so there are 2-3 important things which people have to understand before I do this session. And Shilpa madam, my diagrams are visible or not, just let me know, okay?
Yeah, it is.
Okay, so if I were to look at the ovary and if I were to look at the small follicles which are about to be recruited, please remember that these small follicles before this stage, so at the level of this pre-antral stage, okay, these are small follicles which are completely independent of gonadotropins. They have no role of gonadotropins on them. Okay, so you can't really, you can have an ovarian failure, okay, where also some follicles must be there, but in ovarian failures, gonadotropins, irrespective of the dose which you give, won't work because there is no mechanism in ovarian failure to convert primordial follicles into preantral follicles. That mechanism is absent, as a result of which either HMG or FSH, whatever dose you want to give, even if you give 5,000 units daily, it will not work simply because the mechanism is completely absent. Okay. It is important, very important for all of us to understand that only preantral follicles are having some dependency on FSH, as a result of which they require FSH for these preantral follicles to get recruited. Okay, it is a completely FSH driven recruitment. This is something which is very important. Okay, this FSH is going to actually recruit, or rather you can use a word, rescue some of these follicles from apoptosis. Okay, and in order for you to have multifollicular, so that means when you have multiple follicles to be recruited, whenever you want a multifollicular recruitment, you must ensure that your FSH values, okay, your FSH values will cross the threshold of recruitment of this entire cohort. As a result of which, it is very important to understand that irrespective of the drug which you use, you must start at a good high dose. Okay, should you be wanting to have multifollicular but controlled stimulation. This is the most important take home point, irrespective of HMG or recombinant FSH. In order to understand something more about hpHMG or recombinant FSH, let us just draw actually what happens inside a follicle. Okay, so if I draw a follicle for all of you here, okay, this follicle is going to be lined by granulosa cells. Okay, This is granulosa cells. These granulosa cells closed here are in close contact with the oocyte. Okay, there are gap junctions which are present inside this, and this oocyte is present somewhere here. It is this oocyte which actually promotes the development of these granulosa cells close to the oocyte, which then form obviously the cumulus. And there is a layer which is surrounding the granulosa cells, which is the theca cells. Okay. Now remember, these two guys are independent of each other. Okay, theca cells and granulosa cells are independent of each other. But if you study the follicle very nicely, it is going to be this theca cells which are going to have presence of LH receptors. Okay, and this LH receptor is going to cause conversion of cholesterol to androstenedione. That is a testosterone. Okay, very, very simple. After that, what happens is this androstenedione goes and enters inside the granulosa cell. Okay, and in the granulosa cell, okay, you are going to have the wonderful FSH receptor, and this FSH receptor is going to cause androstenedione to get converted into estradiol, and this estradiol would then escape into the blood in the surrounding cells, which we measure as Doppler, and that is how we look at estradiol levels. Okay, very, very simple. This is basically what I just drew for you right now, is the basis of hpHMG versus rFSH. That is something called as 2-cell 2-gonadotropin theory. Okay, so it is a 2-cell 2-gonadotropin theory. Okay, and this is very, very important for you to understand. Okay, even when this follicle is small in size, it is actually dependent on the theca cell to give LH receptor driven conversion of androstenedione. And this small amount of androstenedione is very, very important for this guy, for this oocyte inside here, because this oocyte is going to be dependent on maturation driven activities on the LH receptor based conversion of testosterone. Very, very, very important concept. As a result of which, when you study a menstrual cycle, okay, the basal values of LH and FSH, okay, LH is not 0. LH is going to be between 2 to 5. It is never 0. In fact, when LH value is less than 1, it is considered to be very detrimental for the oocyte. It is detrimental for this oocyte, and the simple reason being, oocyte is completely dependent on androstenedione, which is converted by the LH receptor. So God also gives some amount of baseline LH for an FSH to cause this recruitment. God has given some amount of baseline LH. Okay, very, very important point. Because this baseline LH is missing when you give pre-treatment with OCPs, as a result of which OCP pre-treatment is contraindicated, because it is going to have a severe drop when you give pre-treatment antagonist. Okay, whenever you give pre-treatment antagonist, this baseline LH will have a severe drop, as a result of which, whenever you have pre-treatment antagonist, the drug of choice is HMG. Whenever you have pre-treatment OCP, the drug of choice is HMG, because HMG has some LH activity. Otherwise, LH is going to go down. Whenever you give a patient pre-treatment estradiol, okay, any form of pre-treatment you give, you are going to reduce the LH, and your drug of choice becomes hpHMG. But before we actually move on, and before we actually try to study, that what is it that we are trying to do in this entire thing, I will give you some more understanding. Lot of people are going to confuse hpHMG, and they will think hpHMG matlab it is just महंगा wala HMG. That is not true. Please remember, recombinant FSH is completely synthetic. Okay, it is produced from a cell line. Okay, and there is no batch to batch variation, no variation, because it is from a same cell line. The hpHMG is actually obtained from postmenopausal urine. Okay, and you must understand 1 or 2 minutes about this thing. This postmenopausal urine requires a special collection, and it requires filtration with chromatography. This is simple. Huh? If you ever want to set up a hpHMG plant, you can appoint me as a consultant. Okay. What basically happens is postmenopausal urine contains three things. It contains FSH, it contains LH, and it also contains some amount of hCG along with all the other impurities, along with proteins, along with viruses, along with bacteria, and along with spores. So your purification process actually wants you to separate either FSH-LH or FSH-LH plus hCG simultaneously from all these impurities. These impurities have to go away. But what happens is, in the final stages of purification, okay, in the final stages of purification, if it is highly purified, then there is LH washout. That means LH cannot survive that much amount of purification. And what you are going to be left with is going to be FSH plus hCG. FSH, when it is 75 international unit, hCG is just 10 international units. And this combination is something which we called as highly purified HMG, wherein there is something called as hCG-driven LH activity. Okay, I hope this is clear, because lot of people will come to you. Every state will have 5 to 10 companies which are marketing HMG, and majority of the companies which are marketing HMG to you are just going to market an HMG which has a combination of 75 international units of FSH plus 75 international units of LH, and this is basically just obtained in 5 steps of purification. Okay, when you want to have hCG driven LH activity, you actually require 7 steps or sometimes even 8 steps. Okay, and this 7 to 8 steps is something which is more challenging to do, and it is important to crystallize this powder at the end, which is very difficult to do. All right, so please be careful. There is a huge difference between hpHMG and HMG alone. I'm sure people who are routinely using it might not be aware, and that is why I thought I must just completely share it with all of you. Okay, with this much in mind, it is important now that we move ahead. We've understood what is hpHMG, we've understood what is recombinant FSH, and let us move ahead in all different types of categories of patients, and we will just say yes, no, yes, no, yes, no. Okay, so we will try to draw a table for all of you. Okay, and how should we select between hpHMG and recombinant FSH? Okay, so the first category of patients is normoresponders. Okay, these are people who are normoresponders. They have an antral follicle count approximately between 8 to 12, and normoresponders with age less than 35. Okay, simple criteria. You again have normoresponders, and now you can have again their antral follicle count, as we know, is between 8 to 12, and we know that now age is more than 35. Okay, very simple division. Okay, poor responders. Okay, very easy. Huh? Poor responders where antral follicle count is less than 6, but age is less than 35. Simple criteria, simple chart. Take a photo of this. This is there in my hospital. Anybody who has visited has seen it in my laboratory also. Okay, and age is more than 35. Okay, then you have a category which is beautiful, where we have hyper responders. Okay, you know what is a hyper responder? Antral follicle count, we normally call it to be more than 12 to 15, irrespective of the age. So in hyper responders, we are not looking at the age. Okay, simultaneously, we are looking at another chart in my hospital, which is called as random start protocol. As we do a lot of oncofertility, we are looking at random start protocol. Okay, then we are looking at agonist protocol in any form. And then we are looking at antagonist pre-treatment. So in whichever case we are giving antagonist pre-treatment, it is going to be predominantly going to happen in patients of low AMH. It is going to happen predominantly in patients who have asynchronous cohort in any stimulation. Okay, now this all is your IVF-ICSI cycles. Okay, We also have a small category of natural intercourse cycles and IUI cycles, where, as you all know, I will just write down irrespective of patient category. Okay, very, very simple to understand. Okay, so if you draw something like this in your hospital and you give it to your staff, next time you don't have to sit down and make any protocol, don't have to worry about HMG, recombinant FSH, nothing. Okay, so before anybody starts throwing out papers in front of me, let me tell you one simple logic. Recombinant FSH will give you more number of oocytes. There is no doubt about it. Okay, and hpHMG will give you more number of TQAs, that is top quality embryos. I must also very strongly tell you that recombinant FSH plus recombinant LH combination, not that effective. I actually don't use it. Okay, I actually don't use it. Nor do I ever use a combination where I've given recombinant FSH for the first 5 to 6 days and then I shift over to HMG. I don't use this either. Okay, I don't like confusion. I don't use this. I will either use recombinant FSH, which actually I don't use in my hospital, or I will use hpHMG, which I use a lot in my hospital. In fact, my entire hospital, all my protocols are based only on hpHMG. Okay, so we know one thing for sure, guys, that what is going to happen in IUI, OI, cycles, we know our protocol. I have shared you my protocol. It is always going to be letrozole plus HMG 150 international units as a standardized protocol. My target is to obtain 3 to 4 follicles. I have told this to you many, many times. Okay, in normo responders, which are age less than 35, one thing we all know, recombinant FSH alone is equivalent to giving hpHMG. We know this. There is no doubt about this. Okay. Please also note all this magajmari we are doing when we are considering frozen cycles. Okay. We are not trying to talk of fresh cycles. In fresh cycles, I'm going to write down. Let me write down as a special thing. In fresh cycles, what do I do? In fresh cycles, my drug of choice is hpHMG. I will come to that little later. Okay. So I have told you whenever I want to do a fresh cycle, okay, it is hpHMG, nothing else. All right. In age more than 35, normo responders, hpHMG, way more superior. It is way more superior than recombinant FSH. Okay. So don't break your head in that. Poor responders of any type, hpHMG. Poor responders of any type, age less, age more, it is hpHMG. Remember, in hypo responders, most of the times you will give a pre-treatment antagonist. Okay, if you give pre-treatment antagonist, there is going to be a severe drop down of LH. In fact, there is something called as LH ceiling. So when the LH value of a patient, basal value of the patient is more than 10, okay, on day 2 and day 3, how do you get that value down? You get that value down by giving a pre-treatment antagonist. You give the pre-treatment antagonist, this LH will become less than 1. Because it becomes less than 1, it becomes hpHMG as your treatment of choice. Random start protocol, again you are giving antagonist before starting the protocol. So your drug of choice is hpHMG. In agonist protocol, you have given agonist and there is severe drop in LH. There is severe drop in FSH as well. HMG will give you both and HMG again becomes your drug of choice. hpHMG, sorry, what I meant is. And in any form of antagonist pre-treatment, it is hpHMG, which is your drug of choice. It is definitely better than recombinant FSH. But the most important word is it has to be highly purified HMG. इंडिया में क्या होता है, some new company who is giving you a better deal has come to you and is telling you, madam, मेरा प्रोडक्ट सबसे बेस्ट है, मेरा प्रोडक्ट I'll give you HMG at 2 rupees per international unit. Kindly write my product. That is just HMG. Okay, please let me tell you, in this comparison, HMG does not exist. It is always going to be hpHMG only. This lecture is only if people want to follow hpHMG. The day you start want to following HMG, you do not need these type of lectures because you are no longer looking into theory. You are looking into something else. And whenever you are looking into something else, academics is not going to help you in any manner whatsoever. Okay. Once you do this, once you understand this particular basics, okay, of how to choose with this type of a diagram, please trust me, every other patient you see, every other pre-treatment you give, you will start using hpHMGs only. In fact, in my hospital, as I've told you multiple times, I've shared this with Shilpa madam and on Opal platforms many times that I have not used recombinant FSH since the last 3 to 4 years. And it has made no difference in my outcomes because frankly speaking, using a combination of rFSH plus rLH or rFSH alone, as I told you, apart from that normoresponder category, is not going to add much to your clinical values nor to your embryo values. Irrespective of what people say that you may get more number of oocytes, you may get less number of oocytes, what matters is getting top quality embryos. And whenever you want top quality embryos, believe me, hCG driven activity, because hCG is going to stick onto the receptor for a longer period of time. It is going to activate cyclic AMP, which is there inside, and that cyclic AMP, which is there, is going to help the oocyte directly. Okay, because the oocyte is going to derive all its nutrition from an hCG driven activity on the LH receptor. Please keep that in mind. I hope there is a very important take home point in this. You may choose the brand which you like, because people always ask this question repeatedly. Every day I get more than 100 messages telling me which HMG I'm using. I'm not using HMG. So I can't reply to you when I'm not using HMG. I'm using hpHMG. Okay, hpHMG, only 2 brands are currently available in India. One is Menopure, which is manufactured by Ferring Pharmaceuticals. Second is Menotas XP, which is manufactured in India as a biosimilar product by a company called as Intas Pharma. In between, for a prolonged period of time, there was something called as IVFM HP. That was a highly purified HMG, which was available from LG Pharmaceuticals before it got taken over by Cipla. And since it has been taken over, the quality and product line has degraded. So it is no longer even available in India. Understanding? So you decide what do you want to use. If it is a question of asking HMG, all HMGs in India, irrespective of what is told to you, okay, irrespective of ASHRAE or Aspire or ASRM, whatever is sponsored for you by any company, is manufactured only by 2 companies. One is Sanzyme and the second one is Gufic Pharmaceuticals. Okay, these are the only 2 people who manufacture HMG, and then there is a loan license distribution for all the companies who distribute it to you. Okay, so I never use any HMG in my practice, so I'm not the best one to answer that to you. Okay, I hope this settles everything down. If there are more questions, Dr. Shilpa, I shall be happy to answer.
No, it's okay. I mean, if you want to answer it in the WhatsApp tomorrow, that's also fine. Or shall we?
No, I can answer 3-4 questions. It's okay.
Okay. So, what is your take on starting the HMG after you give letrozole for 5 days? I'm talking about natural intercourse and IUI cycles.
You can see when you have double follicular development with incremental letrozole or with standard letrozole. Okay, it may happen that one follicle may not be able to catch up to the other follicle. In that situation, you can add back HMG for 3 days maybe to these patients, and it will benefit you, madam. But if it is a monofollicular development, there is no need of adding HMGs.
Okay, so you said that LH-driven activity, the hCG activity is important. So if we start the HMG, say like we start, because many of us are used to starting the IVF stimulation with rFSH. So we start for first 4 or 5 days, and the day that we start ANTAG, we want to change it to the hpHMG. So do you think that it still gives the benefit of the hCG?
No, because listen, that oocyte, which is going to allow for development of granulosa cells and is going to cause theca cells to develop around itself. Okay, you have lost out on the strength of that oocyte by giving that oocyte rFSH alone. Okay, you may do this when you have a patient who has come to you on day 1, day 2, day 3. Okay, and has not taken any pre-treatment. The patient has not taken any pre-treatment, has the most synchronous cohort in front of you, 5 follicles on one side, 5 follicles on other side, everybody less than 6 millimeters. Okay, in that situation, the basal LH is not going to be affected. But in today's modern fertility practice, try and understand the basal LH is going to be affected in some form or the other, irrespective of what you try to do. Okay. So in that situation, in order to avoid confusion, it is better to switch to hpHMG to start off with. It is just 10 international units of hCG. Okay. It is just 10 international units of hCG which is driving that. Even if there are no receptors, we think there are no receptors, but theca cells have LH receptors right from the first day of its origin, as a result of which you have PCOS because of the LH receptors. So it's so simple.
Okay, so have you used urinary FSH in your practice before?
No.
Never have you used? You don't see any benefit, say cost-wise, because rFSH is quite expensive. So
there is nothing called cost when you want to divide the cost of a proper stimulation. The cost of a proper stimulation is going to be varying irrespective of the HMG or rFSH which you use by not more than 3,000 rupees for a stimulated cycle. Okay. So this 3,000 rupees is something which you can add to the patient's charges, and patients will be more than happy to pay. Yeah, this creates a problem when you are buying at a particular price, but when you are charging on MRP, then all this is a problem, right? Yeah. If you are charging as a package, all this is no problem.
Okay. So the batch-to-batch variation that is there with the hMG, the hpHMG, or the hMG. So, I mean, that is a given, I think. I mean, that nobody can do anything about the batch-to-batch variation. So
honestly, I'm sorry to interrupt you here. Batch-to-batch variation is dependent on the API which you select. It is really not dependent on your purification. Okay. If you are selecting a good API, correct? If you want to roam around, you have a Mercedes, right? Red colored Mercedes. You want to roam around in a red colored Mercedes, you have to pay the charges for the Mercedes. You can't go to a Maruti showroom, wear a beautiful sari and say, I am Dr. Shilpa GB, make me drive like Mercedes in this Maruti. That's not going to happen, right? So if you want good quality, you got to pay for it, correct? And the HMGs which are manufactured from a pure API, which is predominantly imported from Argentina or from China, and China or from South Korea, these people are going to have pure outputs. Okay. Simultaneously, you also need to have a manufacturing plant which is going to ensure that your purification through chromatography is so good. Correct. These machines are going to go into 1,000 crore rupees, single purification step machine. And their daily QA/QC is going to cost you more than 2 crore rupees. Okay. So that type of facility currently is not available in India. A lot of people who meet me in conferences act very over smart and tell me, I asked for bioassay report. Do you even know what is a bioassay report? Do people even know the full form of bioassay report? Bioassay report is when you test your final product and you look at the difference per international unit in the weight of a mouse ovary. Which laboratory in India is going to allow you to look at the weight difference of pre-stimulated ovary and post-stimulated ovary on a mouse? Come on. Okay. So these bioassay reports which are given to you are total bakwas. Okay.
Okay. So in your hospital, so if the batch-to-batch variation, if we are looking at, I mean, do you routinely check which batch you're giving? Do you
No. So what I normally do is I have a cold room of my own, as you are aware. I have a big cold room. So normally what we do is we order at any given point in time, we order approximately 1,000 boxes of 1,200 international units. Okay. Of that multi-load. Okay. Which will last us for approximately 2.5 months. Okay. So what happens is by the time a fresh batch has come in. Okay. And we have never found an issue like this ever.
Okay. So coming to these multi-dose vials, that 600, 900, 1,200, which are available now.
Yeah.
And you use mostly 1,200.
Yeah, I use 1,200.
So that 1,200, how many days can you use it? Like, I mean, is there a particular time that you need to finish that 1,200 once you open it?
As long as you are maintaining it in the cold room, there will be no problem, madam, because it has a cap to it, and that cap is vacuum sealed, so there is no problem.
Okay, so to begin with, like the powder form of these injections, which we had to reconstitute, was there.
Yeah.
And there was the solution kind of
Yeah, sterile solution is available with that.
So the liquid form of the drug is available, and also
Pre-filled, yeah, liquid, correct. And the lyophilized, 2 drugs are available, correct.
So, I mean, for people who are practicing in remote areas or like, who can't have like a cold room like you do you think these powder forms are better, or do you think, I mean, it doesn't make any difference?
Powdered forms are good, as you mentioned, if you are going to have frequent electrical issues, temperature, current going away and working on generator and all these things. Okay. But remember, even powder form has to be maintained at less than 20 degrees. Okay. You can't really expose it to heat. The lyophilized crystal inside it will get denatured.
Okay. And see, what is your experience with anaphylaxis reaction with the hMG? I'm not talking about HP. HP may not have that many, but here and there we listen to this anaphylaxis reaction because of impurities which are there.
Correct.
So what is your
take? It is not going to happen due to the impurities. It is something called as preservative, which is used inside, which is aluminum hydroxide for all these drugs. Okay. All drugs use a preservative inside in the form of aluminum hydroxide. So sometimes aluminum hydroxide can cause, this anaphylaxis and all these things.
So in which special situations you use rFSH? I know you don't, but in any of these situations in your practice, in those 150 cycles that you stimulate, so it's a category that you choose rFSH?
In patients in whom rFSH has been started and the patient has left a cycle midway and come to our clinic. Okay, that is the only situation where we continue rFSH, because those poor people have bought it from somebody else. Okay, otherwise we don't have an indication to use rFSH.
So you tell all this only for centers or for practitioners who have a very strong freezing protocols, freezing the facility, isn't it? So you didn't mention about your fresh cycle transfer if you were looking at. So what you usually do in such cases?
See, in fresh cycles, again, because most of these guys are going to be on agonist protocol, very few of them are going to be on antagonist protocol. And even if they are on antagonist protocol, we will somehow try to counsel them for doing a frozen. So let's assume they are on an agonist protocol. Mandatory to use hMG, trigger with 10,000 hCG. Okay. And in your luteal phase support, irrespective of what has been taught to you, you give estradiol hemihydrate plus any form of progesterone gel to these patients. Okay. There, honestly, recombinant FSH does not do any great good to the endometrium, nor do we know if hpHMG does any great good. But we know one thing, that because of this LH activity, there is some increased vascularity, which you will see in the endometrium, because endometrium also has LH receptors in its late stages. Okay. And hCG, when it goes and binds to it, it may help in increasing perfusion. But I am not a big fan of promoting it in that manner. But this is just my observation and I could be wrong. Obviously, I don't have an RCT for all this.
Okay. And like FSH pleomorphism, is there any LH pleomorphism?
There must be, but I have never encountered. Pleomorphism can exist to any molecule on Earth. Okay. You can have pleomorphism to hCG also. Yeah. Maybe that is one of the reasons why you have empty follicle syndromes,
Yeah, correct. So once you stimulate with hpHMG, do you see more of this serum progesterone levels rising on the day of the trigger? I mean, have you?
No, that will never happen. That will happen. Serum progesterone levels will rise on. You want some serum progesterone to be visible on the day of trigger. It should not be less than 0.1, because that peak of progesterone is important for final maturation of the oocyte to occur, as well as for development of a good corpus luteum to occur. Okay. Your rise of progesterone beyond a particular level is going to occur only in cases when you have given antagonist wrongly, or when you have used PPOS protocol and somebody has forgotten to take Meprate in the morning. Okay.
Yeah, I think that's about it. So tell me one thing, like the dose-dependent HMG activity. So
Yeah.
if you maximum up till what dose you use? Do you use 600 HMG?
Never. My maximum dose in my last few years has never exceeded 375 international units.
Okay, so that was for agonist protocol you mentioned that you use.
Yeah, agonist as well as, madam, the ones which are very low AMH, poor responders, no? In that, the threshold of stimulation is only higher. So they will require higher dosages to start off with.
Okay. So if we start 150 from day 3 or
Yeah.
100 from day 3, so on the same kind of patients, like say normal responders with age less than 35. So the response, do you think, is going to be dose dependent? Like
you will cause an iatrogenic low AMH patient, you know, something like that. You don't require 150 international units. Most of the follicles will not get recruited at that dose, madam. You will miss out on few follicles. Okay.
Yeah. So I think, yeah, that's about it. So the rest of the questions, we'll take it on the groups, WhatsApp groups. So thank you so much. I mean, in spite of you having 103 fever, you made sure that you came and gave this excellent concept about HMG and rFSH. I think all of us are grateful for giving this. I think this is something really which many of us wouldn't have even heard. Thank you. Thank you so much.